Should be live, and welcome to another of Machine Medicine's interview series. And we are delighted to have Emilliano Santarnecchi with us, an Italian by origin, but now a professor in Boston. And thank you very much for being with us, Emilliano. Perhaps you'd be so kind as to kick off by giving us a short overview of your of where you started out, how you decided to get into this area, how you actually got into this area, and what gets you out of bed every day, and why you keep on plugging away at it.
Yeah, absolutely. First of all, thank you for inviting me. I'm really happy that we are doing this interview. I mean, I like the format. It's a bit more informal, and we can talk about each other and how we got into what we do now. Regarding how I started this, I have a very, I would call it weird trajectory. I got into neuroscience and research only late in life, like around, I don't know, when I was 30. I haven't done at the time any research, anything. I was not familiar with any neuro technique, electrophysiology. I was a clinician at the hospital in Siena, in Italy. I've been a clinician for a few years. I had a private practice outside. I was also really into doing other things. I co-own a fitness center. I'm really into exercising and these kind of things. I never thought I would be a scientist. In high school, I did a kind of a technical school. Not even like the classical school that you do high school to prepare for college. So I've been going like zig and zag for my entire life, changing jobs, exploring new things. But I guess that was a symptom of my intrinsic, innate, extreme curiosity about life and understanding things. And I always keep moving targets because as soon as I understand something, I want to go for a bigger problem. And so at some point, I met a scientist in Siena, was a brilliant psychiatrist who was doing neuroscience. And he started telling me about his studies on hypnosis and understanding how the brain changes when you are in hypnotic state. And I was like, okay, that's cute. Can I help you? So I started being like kind of a technician, scanning people using the MRI scanner with him while he was doing his experiments. And I got intrigued and I realized, okay, this is something I could really like and do for a living. I realized that all my, again, curiosity and creativity about thinking about problems and solutions and so on could be really channeled into this area, meaning neuroscience and defining new, let's say, understanding the brain, first of all, and then designing new therapeutic interventions for patients. Like, these are big problems. We go after Alzheimer or understanding human intelligence to define better artificial intelligence. Like, these are the big ones. And I realized that's what I want to do. So I got into a PhD program.
Fantastic.
And then I moved here to Boston to finish the PhD, the last year. And they offered me a job. So I came back to Italy for a few months to stay with family. And then I came back in 2016 as a professor, and I've been here since then. I guess that's a summary of how I ended up.
Well, that's one of the most unusual and interesting, I think, trajectories that we've heard yet. So, thanks very much for that. And I think a really great illustration to people that, you're never committed to a particular path. There's always an interesting diversion or even alternative route that can be taken. So, hats off to you for having the guts to do that. So,
I mean,
sorry.
I like to tell this story. Sorry if I interrupt, because I really want to use it as a way to motivate people. I know how tough it is to decide what you want to do when you are a grown up. Again, to be specific about what I said before, like in high school, I did a dental technician school. So I'm licensed dental technician. I could do that for a living. I did it for 2 months. I got bored, went to college. Then I bought part of a fitness center, and I thought that was my thing. I was a personal trainer. Then I discovered I want to work at the hospital as a clinician. That was not enough. So I ended up actually getting 2 PhDs, one in neuroscience and neurology and everything. The other one is in psychotherapy. I'm also a licensed psychotherapist because for many years that's what I want to do. So it's never late in life. Even though I started late, now I'm a professor here in Boston and I have my own program and lab. So I guess my message is exactly what you said. Like, it's.
And did you ever experience any kind of you must have experienced adversity, but I mean, did you ever feel that people were resentful of the fact that you had decided to, take this sort of route a bit later in life, or generally did you find that people were very encouraging and accommodating?
I mean, it's not about them being resentful or anything. It's more about you feeling that you're putting more pressure on people maybe that work with you, because you keep changing and things. And obviously you want to catch up because you start late in life, so you want to go fast in things. But I think that's actually a good thing. And people then understand it because they see that you're very productive and you actually get things done and you have this fantastic motivation. And in the end, we are here to help patients and understand the brain. So it shouldn't be about personal journey. So.
And are you still practicing?
I don't. Here in the US, I don't. No. When I decided that I was going to do research.
Is that something you miss, or?
I do.
Yeah.
I do. I'm trying to help patients in another way with research, but I miss the one-to-one interaction. And I have it here because I run clinical trials on patients, so I'm in contact with them every day. I go and check on them, but it's not like real clinical work. So.
Yeah, I know what you mean. Cool. So there's a few subjects that I'm keen that we should get onto if possible. But one of the first ones that I wanted to talk to you about was, a very fashionable topic at the moment, artificial intelligence. And in particular, an area that you've thought a lot about is how artificial intelligence and maybe computational statistics more generally might be useful, in particular for neurodegenerative disease. Is that right? Why do you think it's a special value here? And maybe in contrast to, say, in genetic disorders?
Mm-hmm. That's a great question. First of all, I started my interest in artificial intelligence because I started my career as a neuroscientist studying human intelligence. So I've done a lot of neuroimaging studies, looking at which networks in the brain, which structures support intelligence, because my goal was always then to use that knowledge to build some kind of neuromorphic AI, basically artificial intelligence that reflect how the brain works, because the brain is definitely the best example we have of the most optimized complex system through thousands of years, that's reached the peak of computational power and efficiency and everything you want from an AI. So that's how I started my journey. Then I start investing on AI directly. And the reason was that we are at the point where we have so much data floating around, data collected in patients of various kinds, like neuroimaging data, electrophysiology, genetics, cognition, everything, you can name it. If we have even longitudinal studies when we collect this data for many, many days, months, years. And at some point, I realized there's no way we can manage all this data, and it's a missed opportunity to keep running studies the way we run them now, in terms of clinical trials to investigate, for instance, novel therapeutics for patients, especially Alzheimer's disease. Because we go one hypothesis at a time. We just select the data we need to look at that specific question, and it takes 5-7 years to run a trial. At this pace, in 50 years, we have tested, 50 hypotheses. Instead, if we organize the data and we work on a larger scale with a bigger vision, leveraging AI, we could actually run a lot of simulation studies that will tell us already at the beginning of a trial if the trial is working. The main problem with clinical trials, without going into too much detail, is that you always rely on clinical outcomes, which are usually symptoms and the results of clinical scales, meaning you ask patients how they're doing, you measure their memory, or these kind of things. But those tools for assessment, like cognitive tests, they are not very, 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 very sensitive in capturing the level of the severity of disease, and you cannot repeat them as many times as you would like every day, to see if there is any hint of an improvement in a patient while it is a drug, for instance. So you only do 3 months, 6 months, 1 year. So you have to wait a year to see if something is working, and that's not how the brain works. If we can capture more subtle signals within the noise in the brain, that tell us, yes, this network is changing and this network is related to that symptom. So if it's changing now, it's a good sign. Probably this thing is working, but we will see it at the cognitive level 7 months from now. But that's a good sign. If you don't see anything changing in the first few weeks or months, probably you should change course. And one way to do all this is to build models with AI, with all the data we have available, and make predictions at the individual level to do precision neuroscience and predict the trajectory for each patient and carefully track them over time.
Yeah. I mean, one of the fundamental problems appears to be the lack of kind of mechanistic understanding, right? I mean, we don't even, I think this is something you discuss in one of your papers, we don't even really have a clear idea if neurodegenerative disease is a set of discrete conditions with underlying separable discrete pathologies, or some kind of continuum in which, you know, there's sort of a family resemblance of which gets clustered into conditions, but actually these are essentially arbitrary divisions on a continuum, and we just aren't carving nature at the joints, as it were.
Yeah, no, that's a very good point. That's the other reason why we want to do this big computational effort to build models, because the more we get data now, and every technique is improving. Neuroimaging, you get higher resolution imaging of the brain, and you can measure things like neurotransmitter that we couldn't like 10 years ago, 15 years ago. Now we get all this data. Paradoxically, many diseases start looking the same, and people start thinking, okay, they actually share symptoms. Now that we can finally measure this thing, we realize that both of these diseases have the same problem there, or maybe 5 diseases have the same problem.
Yeah.
Are we talking about one big problem that just differentiates at some point, or are these all different? It's difficult to support that idea that they're all different now that you can look at the details of what the problem is in the brain. So that's one big problem when we need, again, to look at more data. And the model that we're trying to build now are trying to go after this by being what I call like, we are trying to build neuro twins, to use the wrong term, meaning we try to recreate everything we can about each individual patient's brain using AI and computational modeling. When we go from modeling the behavior of each individual neuron in the brain, and we see how neurons interact with each other, so we talk about microscale modeling. Then we move to mesoscale modeling, when you look at the chunk of the brain and you look at how different type of neurons actually interact with each other within a brain region, how they work to inhibit another region or excite another region. And then you move to macroscale modeling, which is the entire brain, whole brain modeling, when you look at the dynamics of networks in the brain, how subcortical structure trigger activity in cortical structures. So we want to get granularity on each element and then build one big model that encompasses the entire brain. And that's the model that then we would use to try to predict if a patient is going to respond to a therapy or not, if you can identify novel biomarkers of the disease that actually need that granularity. It's a big endeavor, obviously, and we are doing it exactly for Alzheimer's disease. We're trying to build the virtual Alzheimer's brain. But that's, I think, it's necessary. So we need to start from somewhere.
Do you think, though, to be kind of devil's advocate there, like you say, I mean, it's an absolutely mammoth endeavor. Shouldn't we maybe be starting with a condition that we have a better kind of understanding of? Maybe even epilepsy or something, where we're trying to model something which is really more like a kind of hypersynchronization of neuronal firing that we can actually model with and have some confidence that at least perhaps at the level of kind of Hodgkin and Huxley models of the neuron, we have some, you know, we're pretty confident that, okay, it's not perfect, but it's pretty close to what's happening. I mean, is there an argument there, rather than going for, you know, admittedly, this huge disease burden, this massive patient problem?
I completely agree. And indeed, we have 2 efforts ongoing. The Alzheimer's disease is the main one, but I collaborate with another team, which includes some people from the team that work on the Alzheimer's model that are doing the same for epilepsy.
Really?
Exactly. Okay. Because that's the way we can control more of the complexity. I completely agree with you. But at the same time, we are so desperate to understand and treat Alzheimer's that my opinion when we decided to do it was like, yeah, absolutely. I mean, let's find funding, appropriate funding for this, and we were lucky to some funding from the European community and foundations in the US. I think we need to start somewhere again. We will do the epilepsy in parallel. We will do other diseases, but it's also true that we know a bit more now about Alzheimer's disease in terms of which specific neurons and interneurons are involved. There has been a lot of cool stuff published in the past 5 years. So I think this is the right time to try, at least. I don't know if you're going to succeed, but
Yeah, I mean, you're right. It's an absolutely desperate condition. And, I was looking at some of the literature on BBS in nucleus of minor as a potential treatment. All of it, maybe a couple of case studies, which might be encouraging, but actually generally certainly at the sort of level of the studies that have been done, and N is like 10 and 12 in these studies, it looks sort of totally negative. And yet patients are willing to have electrodes put into the deep nuclei of the brain because the condition is just so devastating. So we just have to do whatever we can, right?
Yes, no, exactly. I mean, I run multiple trials in Alzheimer's disease, and really, I mean, when you have the chance to actually interact with patients and you see the faith that they put into your experimental therapy, that gives you more hope that you're doing the right thing, but at the same time, it gives you another kind of wake-up call about, hey, this is serious. Like the chance is to help millions of people, and they're desperate to give to them.
Yeah.
It's absurd. Like, it's another reminder of everything we said before, the need for approaching the problem from a different angle, to use AI, because the fact that we are still here after decades of research on Alzheimer's disease, I mean, I know it's tough, but if you put all the brains that are trying to do research on this planet together and we focus on it, I think we can finally get something useful for patients.
Yeah. What are your thoughts on? I mean, it seems like there are a number of huge challenges in here, right? But one of the most basic challenges just seems bringing different data sources together, kind of interoperability, right? Pooling data across large. I mean, there are literally millions of people with Alzheimer's in the US and Europe, and a network of interacting and communicating scientists, and yet the big data, the biggest data, often studies are, again, looking at like N equals 10, N equals 20 in some of these. It's just, is there a very practical problem here that is people don't want to share data, or the authorities and privacy regulations are actually doing more harm than good? Risk of...
Yeah, it's a good question. Two answers there. I'll try to be politically correct, but also not, because this is a very nice informal conversation. I think we should tell the truth. Science is still done by human beings. Human beings have their own kind of priorities, and they want to succeed. We all want to succeed, and being a scientist is challenging at many levels. So when you have something good, the innate response of people is to keep it for themselves. So when you start, and I've done it, I've set up consortia to share data, to go after Alzheimer's together. You see that people tend to respond, yes, let's do it. But then there is something that doesn't work. And maybe they perceive the same from me when they ask for my data. I'm trying to be very sharing. Like, I gave all the data to Nick to build that virtual Alzheimer brain, but it's never enough. And I agree with you. I mean, we should also work on that, to create a platform that makes other scientists feel secure, so that we can pool the data and at the same time run brand new studies where everything is harmonized, and we use the same sequences on patients for MRI scanning, for instance, or to record the EEG from the brain, or the same cognitive task. Because that's another challenge. Even if you pull data together, sometimes you don't have the same data. But that's science. It's my biggest frustration being in this field. Like, you don't see enough communication. You don't see enough willingness to share for the greater goods. Everybody has to report to their institution. Everybody's challenged by fundings for their studies. So it's a problem. But
and something else that you mentioned that I think is really interesting is this, and I think hugely important, is there's a lot of excitement, and understandable excitement, about AI. But you mentioned another kind of branch of research, which is computational modeling, so actually coming up with models of what the neural code is, how populations of neurons actually perform. And this is something that perhaps doesn't get quite as much coverage, but is hugely important, especially for what you mentioned about developing digital doubles of patients. And do you think in Alzheimer's, are we close to having useful computational models of the actual cognitive function and dysfunction underlying this condition? And if not, how far away are we? Or
I don't think we're close, and that's why we launched that study just 1 year ago on this virtual Alzheimer brain, which does exactly what you just described. I think we know enough now about, again, which subpopulation of neurons and interneurons are responsible for this, so we can model that interaction. And the thing that is fascinating to me is that I can test new hypotheses for treatments right on the model and say, okay, let's say I want to trigger this specific class of interneurons, let's say parvalbumin positive interneurons, which seems to be the real problem in Alzheimer's disease. These are inhibitory interneurons that don't work properly. They're affected by the disease. If they don't work, they don't trigger a microglia response, meaning a neuroinflammatory response in the brain, which is responsible to remove all the bad proteins like amyloid beta and tau. So that's the origin of the problem. But I don't have a way to go directly to that level with therapeutics. But if I can connect that with something bigger, like a whole brain dynamics that I can target, now I can simulate in the model, okay, what happens if I attack here? Do I get some resonance there? Do I change the circuitry? I think we need that. And so we are not there, let's be honest. It will take time, we'll take more data. But yeah,
if it's okay with you, let's move on to talk about therapeutics. Now, a lot of big pharmaceutical companies have moved out of drug development for central nervous system disease. Do you think this is a mistake, or is it more plausible, or should we be thinking actually, well, maybe drugs are not the optimal approach? And that naturally brings us on to another area of focus for you, which is neuromodulation, and why that, is this a superior sort of platform for developing treatments as opposed to traditional drug development platforms, high throughput screening, all that kind of stuff?
Yeah, I don't think it's superior. And obviously I'm biased because I decided to do the vast majority of my work in neuromodulation. So we use magnetic stimulation, electrical stimulation, ultrasound stimulation to go directly to the brain and exactly in the area, region, or network where we think the problem is, which I think is the main difference with drugs. Drugs are great and we need drugs, but they affect everything. They're very noisy and like they affect everything in the brain, even areas that you don't want them to be affected.
Yeah.
And so it's always been like that. I think now going towards precision neuroscience, precision neurology, precision psychiatry, we really want to be specific about what we eat and why and how. So neuromodulation allows you to do that. You need to do it in a specific way, which is not what has been done for the past 20 years. People snap electrodes to the brain and they cross their fingers and they hope that by stimulating almost their entire brain, they will get an effect. Now we need to bring imaging and electrophysiology to do precise targeting for each patient, like individualized targets and so on. But obviously, I think neuromodulation will play a big role for all these reasons. Drug, we know that amyloid is not a problem. If you have to pick one protein, it would be tau, which actually, the level of tau protein in the brain of Alzheimer's disease patients correlates with cognitive deficit and symptoms. The level of amyloid doesn't. So amyloid is going to happen anyway. But if you want to go after tau.
Yeah.
So I started this journey many years ago, and at the time, the amyloid hypothesis was still strong. I see many pharma companies now switching to going after neuroinflammation, which might be actually the common thing here that happens even before protein accumulation. They go after microglia and glia. So I'm seeing a shift, and I hope that we'll come up with drugs that can tackle that. In my mind, the best would be combine the two. Like you have a drug that affects microglia everywhere in the brain, reduce neuroinflammation. And on top of that, I use brain stimulation to go after a couple of specific areas that we know they have additional problems. So for me, neuromodulation, yes, but also drugs.
Very interesting. Yeah, certainly there's one of the success stories in neurological drug treatment over the past 15 years or so has been MS, where biologics and disease-modifying drugs have indeed been hugely successful. So that's really interesting. And then so tell us about as you said, neuromodulation has been done in somewhat sort of perhaps too clumsy or crude a way in the past, and there's nothing surprising about that. Whenever new therapies are developed, that's always the way that they're developed. When new technologies are developed, that's how they're developed, right? Just think about what a phone looked like 30 years ago. So so what do you see as the sort of exciting kind of innovations and developments in neuromodulation that are really driving progress in the field?
Yeah, as you were saying, there's nobody to blame for the clumsiness of what we have done so far. But yeah, I mean, we have done what we could at the time with what we knew. Now I'm really excited about, again, going towards personalized targeting, meaning we do modeling of each patient using everything we can, like from different MRI sequences that look at structural aspects of the brain, functional, the level of perfusion in each brain area. We use PET imaging to look at where the proteins are, for instance, or look at hypometabolism. Then we combine it with EEG, electroencephalography, to look at fast oscillatory activity in the brain, because MRI doesn't have enough temporal resolution to measure this kind of dynamics. And there we get information about maybe the specific brain oscillation that we want to go after. So with brain stimulation, then you can combine the two if you do it right. You can get a multi-target solution that attack multiple nodes of a network at the same time, instead of what we've done in the past 20 years, which is attacking one or two regions. That's it. So we can be a more surgical in terms of spatial resolution. At the same time, we can set the frequency of stimulation. So we just try to entrain a specific brain oscillation that comes from specific neurons and interneurons in that region, instead of going for a massive, like, excitatory stimulation that try to bring everything up, which is what we have done first. So I think personalization is key to really put the field forward. The other things that has happened, unfortunately, is that brain stimulation on one side suffered from the idea that everybody thought it was kind of like electroshock, the old electroshock from the 50s, 60s. So people were skeptical. Then when people start adopting it, you could see a lot of commercially available devices being put out there on the market, which were not optimized for anything. It was just like an attempt to do some neuromodulation to improve your meditation abilities or your whatever, anything, memory. And that has inflated the market and gave brain stimulation this bad name that is like, it's pseudoscience, you snap electrodes like that's on the head, that's not gonna work. So I think now we are finally seeing the light, like we are leaving that phase, and now people have a renewed confidence in brain stimulation. So this time we need to do it right. Otherwise, the field is not going to take off, and that would be a waste.
One of the other things that seemed fascinating, and when I first sort of came across it, kind of surprised me quite a lot, was actually the number of applications that exist in neuromodulation outside of traditional neurological disease. For example, applications to inflammatory conditions like, inflammatory bowel disease, or even potentially rheumatoid arthritis. It's kind of it's like this, just fascinating that by, as it were, reprogramming the nervous system, you can start to reprogram other physiological and endocrine and immunological systems.
Yeah, no, I mean, there is a lot of effort that goes even outside the brain, where people have done cool things, and that's another thing we need to fix, because I've seen a lot of great achievement even in hardware development, which is a big problem for the field. You only have a few companies kind of doing all the same thing and producing the same device. We need a big jump there. We need to really, companies listen more to scientists, or scientists develop their own companies. I don't know what the solution is, but this for the brain, like you see a lot of other application in the neuromodulation field, which are fantastic. Like people are going beyond what I would think we could do. So definitely it's a communication issue, I think. For problem like Alzheimer, we definitely need to bring those people and ideas in.
Yeah, let's see. And what do you think what's the most exciting prospect on the horizon for Alzheimer's? What do you think the first kind of therapeutic is going to be? Is it going to be a non-invasive kind of neuromodulation, or an invasive one, or what's your bet? I know it's asking you to kind of look into your crystal ball a little bit here, but if you were a betting man, I don't know if you are or not, but where would you put your money on the actual first effective therapeutic being developed?
Yeah. It's a tough question, and again, I'm biased because I'm running clinical trials on novel therapeutics that I've developed over the past 5 years. I really believe in those approaches based on what we see also in patients, preliminary data. There is this big story about the lack of, or let's say, the decrease in fast brain oscillatory activity in Alzheimer's disease. There was a great paper published in Nature by a group at MIT, Li Wei Xi's lab, when they showed that in an animal model of Alzheimer's disease, if you boost this activity, which is in the gamma band, you actually trigger microglia. Microglia start and go metabolized amyloid beta and then tau, and then you see in the animal model memory improvements. So that trigger my line of research in 2016, and since 2017, I've been running trials in humans, adapting that protocol using electrical stimulation instead of sensory or optogenetics that they use in the animal model. We are now in our 5th trial with money from NIH, from private foundations. We do this for weeks, every day, for hours in patients, mild to moderate Alzheimer patients, and it seems to work. Like preliminary data are really, really good, and the advantage here is done with a portable device. They could do it at home if you want to do like months or years of treatment. So I think this is a good avenue that we are pursuing. I know about a lot of cool data, the clinical or phase 1 data on neuroinflammatory drugs, the drugs that go after inflammation. I think there's a lot of promise there. I don't know who is going to win, but I see the advantage of neuromodulation because it's really easy to develop a new therapy and then bring it to patient like in 3 months. You just need a device and you go.
Yeah,
For drugs,
seems really powerful, doesn't it? That it can be delivered, the non-invasive aspect of it. You know, even if there were an effective invasive treatment, if there were an equivalent sort of non-invasive treatment, the fact that it could be basically sent in a parcel and delivered to the patient seems to be open up the opportunity for a scalable kind of solution, right?
Yeah, and where I'm going with this application is it's another angle, let's say. It's the fact that we can track the disease more easily with these devices, because the device I use and the one I'm designing now allow you also to do electroencephalography recording from the same device that you use for stimulation. You also can measure voice to get voice markers. You can measure heart rate variability. So when you give this, let's say, at home and the patient does it every day, you also get instant data through the cloud that tells you how the brain is changing and responding in real time. So you can either adapt the therapy and change the frequency, maybe if they're responding or something like that, or you can just keep track of the patients. Now, that's unprecedented granularity in tracking patients every day instead of going to a neurologist every 6 months.
Exactly.
Again, in 2021, it's crazy that we cannot monitor Alzheimer patients every day somehow with wearables, with everything that is available. So neuromodulation also allows you to do that.
Cool. All right. Well, Emilliano, I'm conscious that we've come to the end of our allotted time, but we're going to be looking forward to seeing your results come out and then following your subsequent work and so forth. So thank you very much for your time.
No, thank you for inviting me. This was great.
Cool.